everyone, and thank you for joining the second taping of our webinar today. Unfortunately, earlier we had some technical difficulties, but we did want to make sure we taped this and shared it with all of the folks who registered for the webinar so they could get the value of the information we were sharing. So thanks for joining us for Unpacking the new CMS Medicaid Managed Care Rules webinar. For more than 20 years, Sellers Dorsey has supported transformational change in healthcare, with all of our efforts aimed at improving equity, access, and quality. Partnering with states, providers, health plans, and other stakeholders, we work to strengthen the critical safety net system and achieve results that improve overall population health. Our team of former federal policy officials, Medicaid directors, healthcare executives, and other professionals offer a breadth of expertise, practical and personalized knowledge to help our clients navigate the complexities of Medicaid. I'm Chris Levante. I'm the Chief Administrative Officer here at Sellers Dorsey, and I'm excited to moderate today's panel of Sellers Dorsey experts. And I'll begin by introducing them. Karen Brock. Welcome, Karen. Karen is a managing director at our firm, and she's going to speak about the managed care plan's perspective on the rule. Karen has had several executive positions for major health plans across the United States. Prior to joining the firm, Karen spent 4 years as the president and CEO of Meridian Health Plan. In this role, she oversaw Illinois Medicaid contracts and was responsible for the execution of all program requirements, contract compliance, legislative strategy, and new program development. Welcome, Brian McGuckin. Brian is the Senior Vice President here at Sellers Dorsey, and he's going to be providing the hospital perspective. During his long tenure at the firm, Brian has worked on Medicaid financing programs with both states and providers throughout the country, bringing insights based on his 20 years of experience in the space. He's worked on innovative initiatives, including the first CMS-approved local hospital provider assessment in Philadelphia, and numerous projects with academic medical centers focusing on improving access to quality physician care for the Medicaid populations. Gary Jesse, welcome, Gary. Gary is a senior vice president at the firm as well, and he's going to be providing the state perspective on the rules. Gary has led the tremendous growth of our national consulting practice through business development and overseeing successful client engagements. As a former Medicaid director, Gary leverages his extensive experience with Medicaid managed care, long-term services and supports, Medicaid market advisory and research, and healthcare policy to design and implement creative solutions for clients such as state aging and Medicaid agencies, managed care organizations, PE firms, and solution partners. Before we dive in, I want to set the stage for our discussion today. The Sellers Dorsey team has worked to quickly summarize and provide our initial analysis of the rule and has started considering what the impact is for our clients and the operational changes they'll need to make. Our complete summary report, analysis, and slide deck outlining the provisions in the final rule can be found on our website, and we'll provide links at the end of the webinar. It's also worth noting that this final Medicaid managed care rule was released alongside other final rules with significant impacts for the Medicaid program, including prior authorization, eligibility and enrollment, and access, just to name a few. These rules collectively will have significant operational, administrative, technological, and fiscal implications for states, plans, and providers. With the managed care delivery system as the primary model for delivering Medicaid, through these rules, CMS is seeking to promote consistency and transparency with a focus on improving access, driving quality, and advancing equity for Medicaid beneficiaries. Most changes in the final rule are consistent with those that were proposed last April. However, there are a couple of notable changes that we'll highlight during our discussion today. The most significant changes from the proposed rule are related to the effective dates for the various provisions. For many of the provisions, CMS has extended their proposed effective dates to allow time for states and plans and providers to evaluate and address any areas for compliance. With Sellers Dorsey's deep understanding of the Medicaid program and the new rules, we're well positioned to support those efforts. Now, let's dive into thoughts from our panel of experts. And Brian, I'm going to start with you. What aspects of the rule were to be expected, and what elements did you find surprising?
Well, thanks, Chris. Definitely a lot of what made it into the final rule was expected and really came out of the proposed rule, but CMS did manage to throw in a few surprises. One of the things that was in the preamble to the proposed rule was mention of a potential cap on state-directed payment programs. CMS did not finalize such a cap due to the potential for unforeseen circumstances. But they did reaffirm the importance of state-directed payment programs, that they're a critical funding source for providers. The rule also codifies several policies that have been applied in practice for several years, including the use of the average commercial rate, by which CMS evaluates total payment rates. CMS notes its rationale for looking to the ACR as the benchmark to support equity with commercial payers, as well as to ensure access for Medicaid beneficiaries. I'd say one surprise that was in the final rule was the elimination of separate payment terms for state-directed payment programs. So that definitely goes into the surprise category. But I know we'll talk more about that a little later on in the webinar.
Great, thanks, Brian. Gary, from a state perspective, what surprises did you see?
Sure. Well, I think CMS generally finalized the rules as they were proposed. And I think the biggest change is just, as you mentioned, the notable changes around the implementation effective dates for various provisions. Clearly, CMS was listening to feedback from states and other stakeholders. And so I think we're all happy to see that everything is not due and effective on the same date. But with the magnitude of the rules, along with the other significant sets of rules that you've already mentioned, Chris, this will be a big challenge and a big lift for states. The extra time will certainly be helpful, but there's still a lot here to unpack. The changes that Brian mentioned around state-directed payments are also likely going to create some additional pressure for states as they think about how to incorporate them into their current state-directed payment programs without creating any unintended consequences for providers or plans. And states and other players may be surprised by the sheer magnitude of changes and really beginning to think about the resources necessary to comply with the requirements. But the short answer to your question is I don't think there's a lot of surprise in terms of how these rules look. They certainly reflect CMS's direction, and anyone that's led a Medicaid program would say it's closely aligned with the strategic goals for Medicaid.
Thanks, Gary. So Karen, let's go to you. So from a Medicaid managed care plan perspective, what aspects were expected and what elements did you find surprising?
I think, as was stated earlier, I agree with both Brian and Gary. Many of the provisions represent industry best practices that are currently in place today. And the rules move in the direction that CMS indicated they wanted to go. So I don't think we saw any surprises there. And that is that CMS was hoping to standardize more of the various federally funded managed care programs that are operating today.
Thank you. So next question. So the final managed care rule is one of several rules we talked about earlier, the list of rules that have been coming out of CMS. So what impact do you foresee that the final rule is going to have in terms of operational changes, program design changes, financing implications, reporting or quality performance on state Medicaid programs? And Gary, why don't we start with you from a state perspective?
Sure. I think it's safe to say that states will certainly have their hands full managing implementation of multiple rules with the varying compliance dates. And I think it's just goes without mentioning that many of these states are also facing significant staff shortages and vacancies, and many states, if not most states, are facing budget challenges. States will be looking to CMS for additional guidance, technical assistance, and tools, as well as their health plans and solution partners for assisting and implementing the changes across all of these sets of rules that you've mentioned. That said, when it comes to complying with federal rules, states don't have the luxury of picking and choosing, and so they simply have to do the work required to come into compliance. I think states will also need to identify opportunities for enhanced federal match that's outlined in the rule to support the implementation. As we know, state funding is always stretched. And I think states, plans, and providers will have the opportunity to be innovative and creative in how they approach compliance. I think many organizations across the country will be looking for support. And certainly this is a place where I think Sellers Dorsey could certainly assist.
So Brian, I'm sure safety net hospitals are thinking about this too. So what's their perspective in terms of the operational challenges or financial implications they may see?
Well, Chris, I think the rule will have a significant impact on providers, on hospitals in a number of ways. First, there's a clear focus on transparency, both from a quality perspective as well as from a financial perspective. And providers will need to expand their reporting capabilities in order and invest in systems that help them do that. Providers will also need to work more closely with states and with plans as they develop new state-directed payment programs in order to comply with all the requirements. And I think many existing state-directed payment programs are going to need to change in order to come into compliance. And that's just going to take time and probably a lot of support. The new rule also focuses a lot on performance improvement, and providers will need to refine their SCP evaluation plans to make sure that they're moving the needle year over year, because CMS, I think, now expects performance improvement, and that. But I think they also understand that it takes time and that it's not linear. And I think you can see that in the reporting schedules that they lay out.
And Karen, obviously plans have been watching the proposed rule and anxiously awaiting this because it's going to require them to change some of the ways that they operate. So maybe just some highlights in terms of what plans are seeing in terms of program design or operational changes they need to make.
Yeah, Chris, I would say that, as I said, many of the provisions in the final rule formalize activities that many plans are likely conducting today, or other industry best practices that are apparent today. But plans are really going to need to closely collaborate with states. I think for national and larger plans, they may have already implemented some of these provisions, and so only minor modifications will need to take place. But smaller and regional plans, they may have a bigger lift here. I would also say, as Brian mentioned earlier too, many of the provisions are going to require robust data and analytics. And so stakeholders are going to need to prioritize their data mining and collection, as well as their data sources as they move forward for all the reporting requirements that are coming ahead.
So one of the things that we noticed in the, I guess, nearly 1,000-page rule is the overlapping effective dates and applicability dates. So it's a lot for stakeholders like plans, like states, like safety net hospitals and other providers to kind of plan. So because we'll start with Gary in terms of what kind of recommendations would you make to stakeholders and how do they prioritize what may seem like a lot of next steps that are all overlapping?
Sure. I think, as we've already said, some of the provisions have a longer runway for implementation than others. And I think states and really just about everyone involved in this will be looking to CMS in hopes that they'll issue additional guidance that's necessary for implementation. But I would say states are going to need to get to work now to identify the changes that go into effect first and need to conduct their own gap analysis. For instance, states are going to need to decide what health plan contracts or IT system changes are needed to support compliance. And anyone who's ever been through a procurement process knows that that can be a long process. I think states will also need to determine what they can do internally and where they may need additional external support. So I think my advice is states will likely need to start the procurement processes quickly in order to get vendors and other support in place if they decide they need it.
So Brian, with the safety net hospitals and other providers that you work with, I mean, how are you recommending or how are you seeing them approach the variety of different applicability and effective dates in planning on how to come into compliance with the rule?
Yeah, so as Gary said, some of the provisions have a lot more time for implementation. With the more significant changes for providers, actually not taking place for a few years. So for providers, I think there's a little bit more time, although the time will go by quickly. I think providers will likely need to support to understand everything that's in the rule and how it's going to impact them, particularly as it relates to state-directed payment programs, which are more technical and generally require more complicated solutions. I think as a firm, our initial focus has really been to help educate our clients on the general provisions and then to explore approaches to protect funding, mitigate risks, and then to try to explore the new flexibilities that are offered in the rule.
So Karen, same question to you on the plan side. How are they approaching compliance?
Yeah, I think said another way, the devil is in the detail. Plans have quite a lift ahead of them. They need to be thinking about their providers and subcontracted partners. How do they educate and support them as we move forward with the new provisions? And while not new, as I mentioned, there's a lot of new reporting requirements that states will have to establish and work collectively with the health plans to determine those priorities. Depending upon the number of states a plan participates in, this could create quite a bit of additional administrative work. And so they need to be thinking about the administrative load associated. The new appointment wait times, we talked about that a little bit, but they present some challenges for the plans, especially with the workforce issues we've talked about. And so they'll need to be thinking about how do we go about addressing the workforce and being able to prioritize some of this work. I do want to stress, though, Chris, that I do think this is a tremendous opportunity for collaboration. And I think that's a key you're going to hear weave throughout all of our answers today. But we need to ensure everybody's interpreting these requirements correctly in order to be able to prioritize what's first, what's next. So interpreting them correctly, making sure we all report in the same fashion and apples to apples comparison in the data. And I think the state Medicaid health plan associations have a real opportunity here to work together and collaborate as we move forward with these new provisions.
So Gary, I want to just approach this from Karen mentioned the importance of collaboration, right? Because, Medicaid is so linked with states, with managed care plans, with providers. And I would just be curious to know sort of your thoughts on, and Karen mentioned some around data, but Gary, from a state perspective, what's some of the greatest opportunity for collaboration around data, reporting, quality, et cetera?
Well, I think as Karen mentioned already, the one provision that I think is creating a lot of concern as a result of the rules is the appointment wait time standards. And that's a specific challenge that I think lots of states are facing. Certainly health plans are also facing challenges around provider shortages. And I think the point here is that we face provider shortages regardless of the payer. So, I think around specifically under this provision, because I've been thinking about this one a whole lot, is, lots of states have already established their own standards. So having a federal standard around these types of providers and network adequacy will be a little bit different. So I think around collaboration, a lot of the work will certainly involve states and plans working in tandem to really identify what's the best approach to meet the standards and be in compliance. And so same with saying around access and reporting. So I think when you think about the provisions around access, certainly states are going to be looking at best practices for developing and conducting and evaluating and analyzing enrollee experience. The surveys they've been doing, the secret shoppers, evaluating plan analysis of the payment rates. But I would say, as is quite common within our Medicaid system, having ran a large Medicaid program, the partnership between the state, its federal partners, its managed care partners, and its providers is really the only way that you can support beneficiaries within our Medicaid system. So I think all of the provisions that we're talking about today provide a true opportunity for collaboration. And only through this collaboration will we be success in really implementing many of these provisions.
So Karen, same question in terms of that collaboration. And I'd love for you to touch on the in lieu of service guidance that was in the rule here, which I think can give a game changer to getting people the quality care that they need. But is that an opportunity for collaboration between plans and states? And what else might plans be looking at for that further collaboration?
Absolutely. In fact, that collaboration will foster additional innovation, I think, in this space. States and health plans have been working together since the beginning of managed Medicaid when it was first initially implemented. So reporting on provider networks, payment rates, appointment times. Those are things that plans can and do. Many states and plans have been focused on value-based payment arrangements, as you mentioned, with their providers. And with the in lieu of services being finalized, I think it's a great opportunity to incentivize providers and payers to work together, but including community-based organizations as well in these arrangements, and make it work so that it's sustainable for the long term, that these aren't short-term arrangements. And not just by providing risk-based bonus payments, but by streamlining the administrative functions that go along with many of these new innovations. I think that's going to be critical for both payers and providers. And again, to sound like a broken record, I really feel like the health plan associations here can take an active role and really help foster some of that innovation.
Yeah, well, good point. Good point. And I would imagine all of the associations that represent states or providers and or plans, I'm sure, working very closely with their members to, get out ahead of really understanding how they can share with one another what they've all been hearing to make sure they can leverage the rule appropriately.
Yeah,
so I want to go into some of the access requirements and just ask each one of you from your individual perspective, Gary from states, Brian from providers and hospitals, and Karen from plans. What are the key challenges for each one of those areas with coming into compliance with the access requirements specifically? And Gary, we'll start with you.
Thank you. Well, I think in addition to administrative, the technological, and the financial resources necessary to implement the standards and new requirements, there remains just some key challenges around workforce shortage. And there are many types of providers where we see workforce shortage, but specifically I'm talking about direct care workers that are providing home and community-based services. So considering lots of states have been working through this for a long time, and many people assume that it's all financial, that it's just tied to appropriations, and if you appropriate more dollars, all the workers are there. It's not been my experience, nor has it really been the experience across the country. But I think, Chris, it really poses an opportunity here for states and plans to work with community partners. I think Karen's mentioned the associations. I think academic institutions, to really think about what's needed to make some of these healthcare professions more attractive and sustainable for the next generation of providers. We, in some ways, have been preparing for what we knew would be some of these challenges we're experiencing. We've been hearing from advocates for decades that there will be a problem, and now that problem is here. And so it really is time for all of us to come together. And maybe without the public health emergency and all the other distractions we've had along the way, we might be farther along. But even coming together makes it sound like it's a simple solution. It really is a much bigger issue to be solved and will take some time, regardless of what the requirements are in the rule. Just having the requirement doesn't solve some of these local challenges. But I think, like we always have, working with our federal partners and states and managed care organizations and providers and stakeholders and associations, all of those groups, I think we absolutely have to work collaboratively to try to address the challenges that face us.
Yeah. So Karen, same question to you on the plans in terms of compliance with access.
I completely agree with what Gary said. Health plans are really going to need to invest in resources to implement and comply with the requirements, which I think will present some challenges for the plans as well, given the workforce situation we're in. Some plans are entering into new territory here. We now have to do a payment analysis, comparative payment analysis, comparing the total amount paid for certain services to Medicare payment rates, which may raise payment questions, issues, transparency, concerns, those types of things. There will also need to develop new solutions, including remediation, to support any issues they encounter related to their CAP survey results or some of their access secret shopper results. And this is going to be reported to CMS, and it's going to be published on state websites. So there's a lot of concern about some of the transparency related to how this data will be interpreted. As I mentioned earlier, the new federal appointment wait time standards and the requirement of 90% standard that the plans are going to be held to for meeting appointment wait times, that's going to be difficult for the plans and for the providers. Again, it's going to be reported to CMS. It will also be posted on public websites. And I think, as Gary said, there'll need to be engagement across all sectors in the healthcare system: the states, the providers, the payers, the community-based organizations, and all other stakeholders within the Medicaid delivery system. And so, to summarize, I'd say it's not an easy answer, not simple.
I've heard two themes in Gary and Karen, your responses here. One is the need for collaboration across all aspects of the healthcare environment. The second is obviously workforce. And I know enough and had enough conversation with Brian about workforce. But I would assume, Brian, you also would point to being workforce shortages being an issue for hospitals being able to, comply with the access requirements in the rule.
Oh, absolutely, Chris. I mean, I think as both Gary and Karen mentioned as well, workforce shortages just continue to be a core issue for hospitals nationally, and in particular for the safety net providers that we support. The access requirements in the final rule are definitely ambitious in light of the shortages that exist out there, but they're just really important to ensuring timely access to care for Medicaid beneficiaries. I think the requirements also further reinforce the critical need for Medicaid funding for graduate medical education in order to support recruitment, training, and retention of the healthcare workforce. That's definitely an area that we at Sellers Dorsey do a lot of work in designing and implementing graduate medical education programs nationally to help expand funding for teaching hospitals.
Wonderful. So, Karen, I just want to talk about quality now, right? So, what do you think some of the biggest changes you see in the final rule regarding managed care quality programs, and how do these rules interact or impact the future of Medicaid quality programs now?
Yeah, I think, quality is why we're here, Chris. So I would say, the final rule is establishing requirements for medical loss ratio reporting and quality improvement standards for provider incentive arrangements, which I mentioned earlier, some of the value-based arrangements. And this could be a significant change for plans and how they calculate the revenue, with a heightened focus on the outcomes that these programs are delivering. Similarly, the requirement for states to publicly report plan performance data and report cards, and further plans efforts to work with providers to help drive improvement in outcomes. These are going to be critical components. The information is also intended to promote more transparency, as Gary said, for beneficiaries in terms of the health plan quality performance and how members will select a health plan in terms of their healthcare access. And while plans are currently evaluated by EQROs today, the external quality review organizations, and they're required to conduct CAP surveys today, the additional state administered enrollee experience surveys, the state directed payment impact, and MLR quality reporting is really going to provide members with a lot more information to make their choices. This will present plans with insight into how they're performing against their competitors as well. Back to that apples to apples comparison I mentioned, and how they're performing against peers and where their opportunities are to improve. I think health plans are going to continue to evaluate the opportunities for the in lieu of service arrangements that we've talked about. And will present new value propositions in this regard, and really try to help the providers improve the outcomes that are related to these programs.
So a lot for the plans. Let's go to the state, right? So, how does the rule, Gary, impact states' quality improvement planning efforts?
Yeah, I think the first thing is the rules really formalize what many states are already doing around quality. But as Karen mentioned, I think one of the goals that's clear in the rules is creating more transparency for beneficiaries and other stakeholders who are engaged around the Medicaid programs. I'd say, coming from a state and seeing this work across the country, most states have quality reporting requirements in place. Lots of states have quality withhold provisions and publish their quality data, including comparison charts and report cards today. But I think these rules really will take things to the next level. It'll provide states with more data with which to evaluate the performance of their health plans. But as Karen pointed out, really providing additional information for beneficiaries when they're selecting their health plan. And, I know from my time in leading Texas that, you know, what you pay attention to is really what health plans will pay attention to as well. And why we have scorecards and report cards and all alike that are publicly available, we know lots of individuals within the Medicaid system are defaulted into their health plan. They are not choosing a plan as part of that process. But we know that when the state is paying attention to these provisions, certainly the quality measures and reporting them publicly, that you see all health plans really step up to try to improve their quality. So I think adding to your keys, the themes around collaboration, really another one is transparency and putting as much information as possible so people can make an informed decision, and also just be able to see how states compare state to state in terms of quality.
And obviously, an important part of the quality equation is the providers, right? So, and I know we've been working with a lot of providers over the years on some state-directed payment programs that are tied to quality. So, Brian, I want to ask you from a provider perspective, sort of what impact does the quality aspects of the rule have on hospitals, and I guess specifically around state-directed payment programs?
Sure, Chris. Well, the quality requirements are definitely more robust, particularly with how they align with states' quality improvement plans, which also have more robust requirements, as Gary mentioned, for public comment and updating. The rule promotes flexibilities for providers to engage in value-based programs, I think, in addition to state-directed programs. And with the value-based programs, those have funds that are 100% at risk and really leverage multi-year approvals and other flexibilities that state-directed payments don't really have. And we've been tracking CMS's quality goals for several years and have been getting our provider and state clients really ready for these new requirements, as it's just really the evolution of where CMS wants to go in quality.
So we talked earlier about all of the different effective dates, some pushed out to 26, 27. There's one, of course, that becomes effective September of this year. So I want to ask a little bit about that because that's coming down the pike pretty quickly. In the final rule, CMS is going to require that state-directed payments need to be included in the MLR calculation. And like I said, this goes into effect in 24, later this year in September. So let me start with Karen. What resources do you think plans need in order to be compliant with this provision?
Well, I think back to that issue of collaboration, I think the provision is really an opportunity for the plans, the providers in the state to come together on innovation around this. I think they can work more closely around the design and implementation of state-directed payments collectively, and ensure that the critical funds through these payment mechanisms continue to support access and coverage for Medicaid beneficiaries so that they can see the high quality providers that we all see today. The rules make MLR reporting consistent with what commercial plans are doing. So if you're a large national payer and you have a commercial product line, there's probably not going to be a whole lot of lift here for you. But if you're a smaller regional plan, this could be significant in terms of the resources required to meet this requirement. So I would think about it from that perspective.
Right. It's helpful. Not all plans are created equal here, right?
That's right.
That's the point. So
That's
Gary,
right.
from a state perspective, in terms of compliance with this provision later this year?
Sure. I think it's important, again, for states and plans to work together to reconcile the information that supports a plan's MLR reports that now will include the state-directed payment. I think the provisions support transparency. We've talked a lot about that today, and alignment across plan-led and provider-led efforts to improve quality, access, and equity. So I think, again, as Karen said, I agree with her. I think it creates a unique opportunity for plans to work with providers, but certainly for states to engage with both plans and providers to ensure that they're aligned in terms of overall goals for the Medicaid program.
So as we mentioned earlier, and we'll bring this to a close in just a second, but we talked about the fact that this rule was nearly 1,000 pages, and a lot of it was expected because it was based on what was proposed. But one of the most significant changes that was included in the final rule, Brian, we've talked about this, was related to the prohibition of separate payment terms by 2027. Now that seems like it'll be a long time away, but certainly could be here before you know it. And given that more than half of the current CMS approved state-directed payment programs support payments to providers that are through separate payment terms, how can, well, let me start with you, providers begin to plan for this transition? Because as we said, 27 is going to be here before we know it.
Yeah, Chris, I think we definitely expect sub-regulatory guidance in this area, as gray areas are just typical when rules like this come out. And I think that's definitely the case with state-directed payment programs and the separate payment terms. For all the programs that we support, we're reviewing them for compliance, particularly with the separate payment term provisions. And we already do have some programs that we think already comply. And so we're looking at those to see what we can glean in terms of lessons learned for implementation. Things like risk mitigation strategies and how you can reduce the administrative burden. I think, as Karen and Gary have said multiple times throughout the webinar today, that it's really an opportunity for plans and states and providers to work together. And I think they're going to need to do that more on state-directed payment programs now with this rule out there.
Gary, just briefly from a state perspective, anything you'd add in terms of what states should be focused on?
Sure. I think the key step here is for states to facilitate open, honest dialogue with providers that are part of a state-directed payment program, as well as the state's health plans who are administering these funds. One, to understand, and two, to address the needs and concerns of all the stakeholders. So now more than ever, Chris, I think it will require stronger partnership and certainly trust among those parties. Certainly, I think it's intended, the goal is to increase access to high quality care to Medicaid beneficiaries. It's why we're here. And it's also important to keep our focus on that as we work through some of the technical details of the compliance, as Brian pointed out. And I think for states, there is a potential for the provision to provide for a more cohesive, streamlined flow of funds for both services and state-directed payments, so we can eliminate some of the bifurcated strategies through which these dollars have been supporting previously.
So that brings the end to my questions, but I did want to open it up for you all. Again, the rule was pretty significant. There were other rules that CMS has been publishing. Any closing thoughts, anything that we didn't cover today that you want to make sure we addressed in the webinar?
I would just say, Chris, as I indicated early on, the devil is in the details. And so a lot of these sub-regulations we're going to have to be understood. And before this is going to be a smooth transition. So I would expect some bumps along the way, and lots of dialogue between all the stakeholders that we've talked about today. But it is, I think, the movement that CMS has been talking about for a long time, and it's the direction we're heading, and how we get to work together to do that is going to be our success.
And Chris, I just add that, we saw the draft rules, and sometimes the draft rules look very different than the final rules, but the final rules are very similar. But it doesn't mean everybody's gotten started on what they were expecting. So I think, as we've talked about today, if we haven't scared anyone who will be listening to this webinar, it wasn't our goal. But I think that at the end of this, there is tremendous work to be done in this rule and all the other rules. And so I think as states and plans and providers are trying to work through, I think, as we mentioned earlier, this gap analysis is going to be critical in setting up a plan with the effective dates. But I think what we have to be careful and not lose sight of is that in many ways, these provisions that are supported across all of these rules are really to modernize and to improve the experience for our beneficiaries. And so I think when you think about it from that perspective, the beneficiaries in the Medicaid program deserve this transparency. They deserve this focus on quality, and they deserve improved access. But getting to the finish line and making sure that everyone's ready and compliance can be achieved can be tricky.
Yeah, and Chris, I think Gary said it really well. I think we all support the overall goals of these rules, which are transparency, access, and quality, definitely. And at the same time, a lot has come out from CMS over the past couple of months. This rule, the access rule, several others. And so I think it's definitely going to be a challenge for states, providers, and plans to really understand what is going to be asked of them and to make it happen.
Well, thank you all for joining. I've enjoyed this conversation. This is, in full transparency, the second time we've had this conversation today because we had technical difficulties earlier, but I enjoyed it nonetheless. So thank you for joining us, Brian, Karen, and Gary. Thank those who have joined this webinar and are watching this later. I would like to remind people to visit our website at sellersdorsey.com, where we house our comprehensive summary report. We'll house these summary slides that we will share, and we house other additional information that could be helpful in understanding this rule. If you have questions that weren't addressed here or aren't addressed on our materials, please email webinar, WEBINAR, at sellersdorsey.com, and we will endeavor to get back to you as soon as we can. As you know, this is a very big, complicated rule. It's a rule that CMS doesn't release once in a decade. So we understand it's going to be messy, as Karen said. We understand there's going to be bumps. In some instances, we understand there may be more questions than answers, but we're looking forward to answering those questions with you, our partners, and our clients. So feel free to reach out, and we look forward to being on this journey with you all. So thank you very much, and have a wonderful day.